Welcome everyone to our citywide psychiatry grand rounds. It's a great pleasure to welcome you. My name is Raj Rasasingham. I'm the CPPD director for the Department of Psychiatry. We're so grateful today. We have a wonderful array of speakers from the Women's College program. Before we begin, let me first begin with the land acknowledgement. I would like to begin with an acknowledgement of the land on which we work, study, and live. Before I read it, I would want you to take a moment to situate yourself and think about the land under and around you. We recognize that many Indigenous nations have a long-standing relationship with the territories upon which the sites of the Department of Psychiatry are located that precede the establishment of the University of Toronto. We acknowledge our presence on the traditional treaty of many Indigenous nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat people. Today, this land is home to so many diverse First Nations, Inuit, and Métis people, and we're grateful to have the opportunity to live, work, and gather on these territories. We acknowledge that Toronto is covered by Treaty 13, signed with the Mississaugas of the Credit, and the Williams Treaty, signed by the multiple Mississauga and Chippewa bands. Since this event is a virtual gathering, a singular land acknowledgement does not capture the richness of our distribution across many locations. There are few places on Earth that someone before us has not called home. So thank you. Just a couple of housekeeping items. An evaluation link will be sent to all attendees after the presentation, and please fill it out. We know we really appreciate your feedback as we continue to work on the citywide psychiatric grand rounds. And as I mentioned, sincere appreciation to Dr. Dana Ross, Dr. Nancy McCallum, Aysha Butt, Dr. Giovanna Martinovich, and Dr. Simone Bigode, and the Women's College team for doing this grand rounds for us today. Our next citywide grand rounds in February 25th, 2022, and I'll update that at the end as well. And just one last thing before I move it to Vicky Sergiopoulos is, for your questions at the last 15 minutes, please put it in the Q&A section. We'd prefer that if you put your questions in the Q&A section, so that'll be helpful for our moderator today. Without further ado, I will pass it on to Dr. Vicky Sergiopoulos, our Vice Chair of Clinical, to give our department welcome.
Welcome, and thank you for joining our monthly citywide grand rounds. I hope everybody's well, and we hope to see you again next month. But for now, no further comments from me. It's my pleasure to introduce Simone Bigode, the psychiatrist in chief at Women's College, who will introduce the panelists.
Thank you, Vicky. I'm Simone Bigode. I'm the head of psychiatry at Women's College Hospital, and this is Women's College Hospital's first citywide grand round. So we are really excited to be here, and thank you very much for the opportunity. And Dr. Giovanna Martinovich, who is our faculty development lead at Women's College, and who also is our wonderful organizer of our Women's College Grand Rounds program, is going to be the moderator today and introduce you to some really exciting people and work that is happening at Women's in our trauma therapy programs. So I will turn it over to Dr. Martinovich. Thank you all for coming.
Thank you so much, Dr. Bigode, and to all for the lovely introduction so far. So it's my pleasure to introduce our three speakers today, Dr. Dana Ross, Dr. Nancy McCallum, and Aysha Butt. Dr. Dana Ross is a psychiatrist and clinician educator in the trauma therapy program at Women's College Hospital and an assistant professor at the University of Toronto. She is leading 2 research projects that will expand access to treatment for complex trauma in Ontario, and is in the Education Scholars Program through the Centre for Faculty Development. In her clinical practice, she provides trauma-focused group psychotherapy and is passionate about healthcare innovation, teaching, and relationship-centered care. As a First Nations physician, Dr. Ross is a mentor through the Diversity Mentorship Program at the University of Toronto and an advocate for trauma-informed care. Dr. Nancy McCallum is a psychiatrist at Women's College Hospital and an assistant professor at the University of Toronto. She is the medical lead for the trauma therapy program and has been involved in developing trauma-focused programs and services at Women's College Hospital for nearly 20 years. In her clinical practice, she provides trauma-focused individual and group psychotherapy in the trauma therapy program. She is also trained in many psychotherapeutic treatment modalities for the sequelae of trauma, including EMDR, sensory motor psychotherapy, and internal family systems therapy, and has been involved in research related to the use of neurofeedback for trauma survivors. Aysha Butt is a research coordinator in the Women's Mental Health Research Program and Trauma Therapy Program at Women's College Hospital. In addition to working on projects related to perinatal mental health, her primary role is to coordinate 2 research projects that aim to increase capacity in delivering trauma-focused care across Ontario. She is passionate about understanding barriers and facilitators to mental health care access and implementing innovative mental health care delivery models that may influence policies for underserved communities through Community Alliance. I'll turn it over to the presenters now. I'm so excited to hear them speak about some of the initiatives and work that's being done at Women's College.
Okay, so I'm just going to share my screen here. Thank you so much, everyone, for that introduction. And for everyone who's attending today, we heard that there were 475 people registered today. And so, while it's a little bit daunting, I'm going to imagine lots of friendly faces out there behind the black boxes on the screen. So Dana and Aysha and I today are going to talk about Resourced and Resilient, a virtual training program on complex trauma for community providers. And as required, I'll let you know that we have no conflicts of interest to declare, and our objectives that we plan to get through today are describing 3 stages of trauma therapy treatment, discussing some highlights from the literature on virtual education initiatives in healthcare, and explaining the rationale, methodology, and outcomes to date from our trauma therapy project for community partners study. So I'm going to go first, and I'm going to provide some background before Aysha and Dana tell you more about the community trauma therapy project. I'm going to describe what we mean when we refer to childhood interpersonal trauma and talk about the stages of trauma therapy and recovery in order to situate the intervention we're going to talk about. And I know rounds generally includes a case, and since we're talking about education and program development, the case we're going to talk about is our program, the trauma therapy program at Women's College Hospital. So I'll tell you about how this project came about by sharing a bit of the story of the trauma therapy program, and I'll describe the Resourced and Resilient group that this project is centered around. So what we mean by childhood interpersonal trauma in our program is experiences like physical abuse, sexual abuse, emotional or verbal abuse, neglect, witnessing violence or abuse, or traumatic loss that occurs before the age of 18. Most often, our patients describe these experiences happening in the context of caregiving relationships or in the absence of adequate care. So this impacts on the development of relational and self-regulatory capacity of the nervous system, resulting in extremes of physiological and psychological arousal, and that then necessitate compensatory coping strategies that can be maladaptive or harmful. So really what we're saying is that childhood trauma affects how we think, how we feel, how we behave, and how we relate. That wide range of symptoms and adaptations described by Judith Herman as the construct of complex PTSD. The sequelae of childhood interpersonal trauma in terms of mental and physical health are well known, particularly from the Adverse Childhood Experiences study by Vincent Felitti. We're not going to review all of that here for time's sake, but I would highly recommend that you refer to the previous citywide grand rounds in October of 2021 by Drs. John Hunter and Bob Maunder for an excellent review and also a really beautiful and compelling description, which you can read about in their book as well. Their book is Damaged Childhood Trauma, Adult Illness, and the Need for a Healthcare Revolution. So, stages of trauma therapy. So the idea of a staged approach to trauma recovery and trauma therapy isn't new. The current widely accepted stage model is built on the foundation of Pierre Genet's work, goes back to the 1890s, that's been conceptualized by Judith Herman in her 1992 book, Trauma and Recovery. So stage 1 involves establishing a sense of inner and outer safety. Having grown up in an unsafe world, survivors have an ongoing sense of lack of safety of inner experiences and the outer world of relationships. Their lives are disrupted by the inner turmoil of big feelings and the outer chaos of unstable, unsafe, or absent interpersonal relationships. And they often cope in these harmful, maladaptive ways, including dissociation, substance use, disordered eating, self-injury, other high-risk behaviors. Stage 1 treatments aimed at improving regulation of inner experiences and building capacity to more safely manage their inner and outer worlds. And then stage 2 is what most people would think of as the core of trauma recovery. When they're safely able to tolerate it, the survivor's work becomes to remember and reflect on the traumatic experiences and relationships in a new way as a resourced adult in the present, not a terrified and helpless child in the past. And to make new, more self-compassionate meaning of it, and to mourn the losses and heartbreaks. This leads to stage 3, where the survivor can now begin to live a life that's not centered around strategies to survive a dangerous world, and make safer, more fulfilling choices based on the perceptions of the present that aren't overlaid with the fears of the traumatic past. So we're really going to focus on stage 1. And so as Judith Herman, for instance, the goals or tasks of stage 1 trauma therapy are naming the problem. This really isn't so much about a formal diagnosis, but really acknowledging the trauma and its effects, making the connection between the past and present, the past trauma and the present struggles and symptoms. The next task is building or restoring a sense of inner control. That involves managing symptoms, developing emotional self-regulation, reducing shame, and building self-compassion. And then also building or restoring a sense of outer control, establishing a safe environment that includes safe, supportive relationships with a balance of closeness and boundaries. Psychoeducation and skill building are commonly used evidence-based modalities in the initial stage of trauma recovery. Now, our case. So the trauma therapy program, or TTP, as we sometimes call it, at Women's College Hospital, is a primarily psychotherapeutic treatment program for survivors of childhood interpersonal trauma. We offer mostly group therapy, including a day treatment program, a foundational stage 1 psychoeducation group that we'll tell you more about, and a series of more specialized stage 1 groups that include CBT, body-oriented therapy, expressive arts therapy, and relationship-focused therapy groups, as well as stage 2 trauma processing groups and individual therapy. We started in 1998 as WRAP, the Women Recovering from Abuse program, which is our 8-week day treatment group therapy program that uses a multimodal approach, and it's primarily a stage 1 program. And then in 2003, we expanded and began offering time-limited individual therapy with the intention of offering specialized trauma therapy to our WRAP graduates and to the wider community. We learned 2 things from this. The first was that lots of people wanted to work on stage 2 trauma processing, but in some ways weren't ready. They didn't have the necessary safety and stability capacities to stay present and remember the past, would often get overwhelmed or flooded by the work. And so a lot of stage 1 work was happening with our individual therapy clients. The other thing that we learned is that there's lots of demand for trauma therapy. Like any program that opens to external referrals, we grew a wait list, and quickly. My recollection is within the first year that the wait list grew to probably a year or 2 long for individual therapy. And so we did what any group therapist would do, and we developed a group. And the group that we developed is what we refer to as the Resourced and Resilient, or R&R group, that offers stage 1 work to help the patients get ready for further therapy. So our Resourced and Resilient, or R&R group, was designed as an introduction to trauma therapy to help clients to begin to understand their own experience and build skills and capacities to cope with it using a psychoeducational approach. It's meant to be of manageable intensity for those who are new to trauma therapy, so we limit people sharing trauma stories and stirring up relational dynamics in the group, and instead encourage reflection on how past trauma is showing up in present day experience. Even though it's educational, it's a therapy group, not a class, and participation and engagement is really encouraged. Group members discuss how they relate to the material, share their own experiences of struggles and successes in coping with the impact of trauma, and offer support to one another. The role of the therapist is to teach the material, to facilitate group discussion, and to help the participants modulate their level of arousal as they engage with the material. All patients who come for therapy in TTP begin with this group, as we also use it as an extended assessment tool to help guide next steps in treatment within the program. So here's an overview of the curriculum of the group. We introduce themes around understanding the impact of trauma, including PTSD and complex PTSD, emotional and physiological self-regulation, the neurobiology of trauma and how it affects our brain and the animal survival responses of fight, flight, freeze, and feign death. Talk about re-experiencing symptoms like triggers and flashbacks and how to cope with them. We introduce CBT and the thought record skill. Talk about interpersonal skills and boundaries, explore relational reenactments, and we teach skills including breathing exercises, self-care, self-soothing, and grounding, and mindful self-study. The interventions that this group is based on are evidence-based. There's a lot of literature supporting the use of psychoeducation, CBT for trauma survivors, but we wanted to look at the package that we're offering these interventions in for the quality of our program and for program planning and development. And so we collected some data. So I'm going to show you the data that we collected, some of it. I'm going to start with the caveats, actually. This is unpublished data that was really just collected for QI, so you can take it with a grain of salt. It's not a rigorous research protocol. It's, there's no control group. The data shown is from completers only. And so as much as I might show that there was statistical significance in that, it's the, you know, the interpretations of the data are quite limited, but we thought we'd share it anyway, because we really wanted to get a sense if we're going to build more of our program based on this, you know, is what we're offering something that works. So we looked at 5 groups over a period of 4 months in 2019. These are in-person groups pre-pandemic. There were 7 to 12 participants in each group. There were 5 different pairs of facilitators. 45 participants started in those groups, and we had an 84% completion rate. The average ACE score was 5.37 out of 10. So quite high. There were lots of 7, 8, 9s in that group. And we had the participants, we had the facilitators get the participants to complete the post-traumatic checklist, PCL-5, and depression, anxiety, and stress scale before and after the group. So in terms of the PCL-5 scores, although my bias in this, I kind of thought an 8-week psychoeducational group, I don't know if we're going to see very much difference. And people might even get worse, you know, if they're new to trauma therapy, this could just be opening people up and their symptoms might actually get worse. I felt like it's early in the stages, and it may take longer than that to start to see differences. But we did actually start to see some differences in their PTSD symptoms. Of note, if we look at the total score, the average starting score was around 45, which is clinically significant because a score of around 31 is considered the cutoff for the diagnosis of PTSD. Saw a drop of about 10 points there, which is considered to be clinically significant. Also saw decreases in avoidance, cluster of symptoms, the mood and cognition symptoms, and the arousal symptoms of PTSD. In terms of depression, anxiety, and stress, depression scores, we saw a decrease there, stayed in the moderate range. I mean, this is just an 8-week, hour and 45 minutes a week, some psychoed, excuse me. And the anxiety scores tended to decrease as well, starting out on the edge of extremely severe and dropping to the edge of severe to moderate on average. And again, some decreases in the stress scores. So again, lots of limitations to that data, but looks like it's going in the right direction. The other thing is that participants often report really positive experiences of this group. And these are some quotes from a group that Dana and I finished recently, what our participants were saying at the end that really speaks to the kind of self-compassion and reduction in shame that people can experience through psychoed. So our participants would say, I'm not broken, I'm a trauma survivor. I'm not unusual. This is just how humans cope. And these are good people, and maybe I am too, and I don't need to feel so ashamed. So we have what we think is a good intervention that patients appreciate, and it seems to be helping some folks. We're currently offering this group 9 to 12 times every 4 months, and we have a wait list of about 700. We had about 80 new referrals a month. So here's the problem, the math doesn't work. If we have a backlog of 700, get almost 1,000 new referrals every year, and we can serve about 360 participants in our groups per year, we're in trouble. We can never serve all these people. And we'd eliminate all of the rest of the services we provide in trying to. including the stage 2 work that our therapists have specialized training in and that's so hard to access in the community. So in order to provide reasonably timely access to trauma therapy, we need to address this supply and demand problem. We can't do it all by ourselves. And so one strategy that we're exploring is building the capacity of other therapists to offer this group in their own settings with clients that they might otherwise refer to us in TTP. So Aysha's gonna now tell us some more about how this project is developing. And I will pass it over to her.
Great, thank you. So I'll be talking a bit about the trauma therapy project, specifically the first 2 phases which have been completed. So the trauma therapy project is a 4-phase project that started in 2019, and we're currently on phase 3. So we did receive ethics approval for phase 1 in September 2019 and $50,000 in funding for phases 1 and 2 by the Hope and Grace Foundation. In this phase, we've recruited 3 community organizations who participated in focus groups to evaluate their unique needs and wants for a virtual stage therapy group, a training program. And so 2 of the focus was done virtually. So the next slide shows some of the key themes that came out of the focus groups. So we did have a total of 16 healthcare providers participate in these groups. And so for facilitator information, we just asked participants about their current and past roles, previous education and experience that they had. Overall knowledge on trauma therapy includes any that they have in delivering trauma therapy, how comfortable they are in facilitating trauma therapy groups, and any formal training, which includes education or workshops. And so some participants had experience in delivering therapy, but not specifically trauma-informed care. Others said that they are familiar working from a trauma-informed lens. And then we had a handful of participants having experience with individual and group counseling for those who have experienced on thoughts of offering a foundational trauma therapy group. And so that could be divided into these 3 subcategories. So there's benefits, concerns, and facilitator needs. So one of the main points that were brought up about the benefits of offering a foundational trauma therapy group was the piece around accessibility. And so that's really about giving the community who have experience with trauma access to free group therapy, where they'd otherwise need OHIP coverage or would experience long wait lists to receive access to therapy. Participants also brought up that offering this group may be a stepping stone for people accessing other services that look deeper into trauma. Because a lot of the time, what some of the participants say that they hear saying is that they're afraid of being overwhelmed by what some of their experiences have been. And so if they had some coping skills and understanding that are offered in a foundational group, that maybe it might help them to move to that next level where they can actually kind of start glancing at the trauma and opening up a bit more. And then in terms of concerns, some of those that were mentioned include organizational capacity, such as lack of space. And so these focus were conducted pre-pandemic. So now there is obviously the option of converting things to virtual groups. Staffing support to run the groups was another barrier that was mentioned. And timing of the group so that it could be as accessible as possible to the population, but at the same time being able to fit it in existing staffing schedules. And then some participants also mentioned that they don't feel very confident with their ability to offer the level of support that's needed for this population. And that's mainly from those who don't really have much experience dealing with the population. And then the last thing that was mentioned in terms of concerns was concerns around group structure. And so that's really about asking participants to commit to a weekly group for 8 weeks and to attend for 2 hours at a time. And so they saw that as a potential barrier as well. And then facilitator needs, we then asked participants to share what would then be helpful for them to address these concerns. And so supervision was consistently mentioned throughout each of the focus groups. Participants did say that they wanted to have a support person, for example, a therapist at Women's College Hospital, who could discuss how to improve, what worked, and how things could be better for next time. And they also mentioned that it would be helpful having a set of materials that they could be using for training purposes and to refer back to when delivering these groups. And so that's kind of the purpose of us creating this, these modules is for them to refer back to. And then when asked more about the training piece and any foreseen barriers to training, time was a big factor for participants. They thought that having 8 training modules was reasonable. Take anywhere from 30 minutes to 2 hours to complete each module at their own pace. Then we asked participants about what they'd like to be seen covered in these modules and what kind of formats best suit their learning needs. So participants expressed that the content should acknowledge diversity and incorporate culturally sensitive information to promote accessibility for harder to reach populations. Importance of language, whether that be the use of pronouns, terminology, and also access to translation services was also mentioned. And then we heard a mix of different learning methods preferred by our participants. So some mentioned that they would like to watch videos. Others preferred audio clips, for example, podcasts, so that they can do other things simultaneous to listening to these. And then some prefer to work through materials, whether that be either accessing handouts or completing reflective exercises. These were some of the key elements that we took back to incorporate within the training modules to promote the mixed learning styles. And then finally, experiences with collaborations. We asked them to share any experiences that they had, whether it be positive or negative. And this was just so that we can have a sense of what works, what not to do, and how to promote a healthy relationship between our organizations. So then we moved on to phase 2. And so after collecting everyone's feedback, we then designed and built an online asynchronous training program, which contains multimedia content modeled after the Resource and Resilient group. So in 2020, we recruited 3 additional community partners. So we had 6 sites total complete the virtual training program. And in total, we had 5 healthcare providers complete the training at that time. And the feedback from the sites on the training modules focused on content and delivery platform, improved subsequently made to the virtual training program. And then this was followed by virtual consultations, which we conducted with each of the sites to discuss implementation, looking specifically at barriers to implementation, and then what additional supports may be needed. For example, having the virtual supervision from therapists within the trauma therapy program while our community partners were running their initial groups. So then we had participants complete pre-post questionnaires as part of the evaluation component of the training module. It's measured attitudes, beliefs, and knowledge levels of participants. And so the following slides are just very brief overviews of some of these results. So we had 36 participants complete the questionnaires. So figure 1 here shows that majority of the participants were in their mid to late years of their careers, with most working within the healthcare field for more than 6 years. And most participants, as shown in figure 2, spent on average 5 to 7 hours to complete the modules. And that rounds out to just under an hour for each module, and which that aligns with the expectations that were mentioned from the focus groups. And then here, so figure 3 and 4, 96% of participants strongly agreed with the idea that multimedia format improved their experiences of completing the modules, and that they'd also recommend the course to their colleagues. So being able to combine the different methods of learning that participants had mentioned during the focus groups really helped keep them engaged with the content. And figure 5 shows that 93% had reported that the time spent completing modules was consequent with the knowledge gained. And so that's really positive feedback because it speaks to the material that was presented as being helpful, and that perhaps those who spent a lot of time going through the content and reflecting on each component would really reap the benefits out of what the training module could offer. So then the next slide shows a comparison between participants' confidence levels in co-facilitating a trauma focus group with their clients before and after completing the training modules. So participants' responses showed that completing the e-learning modules helped improve their trainees' levels of confidence on co-facilitating a trauma focused group with their clients. Shown as figure 6, before completing the e-modules, 86% of respondents were not confident in co-facilitating And then figure 7 shows that after completing the E-modules, 75% of respondents were at least somewhat confident in co-facilitating a session. And so this information's motivating, I guess, to say the least, as it means that the training modules are working in increasing knowledge and confidence levels of healthcare providers. And it's also very approach in developing the course, and we'll continue to what might increase the confidence level further as we continue to develop the course in the future. So now to Dana, who'll walk us through some of the components of the course in more detail. Dana, over to you.
Thank you, Aysha. All right, thank you. So we had 3 kind of things we wanted to really keep at the forefront of our mind as we were developing the trauma therapy project, but also as we continue to iterate. So community, how can we increase community capacity to deliver trauma-focused care? Virtual, how can we harness the virtual environment to increase accessibility to trauma-focused care? And then education. How can we use best practices in education to effectively deliver an e-learning course that meets the needs of our community partners? And next slide, please. So this is the landing page. So if you were part of our community partnership and you were taking this, you would have an individual login with your email, and then you would come to this landing page. So Women's College Hospital Trauma Therapy Project, a virtual training program for our community partners. Learn how to deliver our resource and resilient psychoeducation and skills trauma therapy group. And then you click through start the program. If you want to stop sharing here, Nancy, I'm going to take you into the live environment. Perfect. Thank you. Okay, so I'll orient you here. So we've landed on your landing page. You're now going into your specific course, and this is exactly what you would see on your screen if you were working through this training program. You see you're in the resourced and resilient place, or in the right place. You've got your completion here. We haven't started, so we're at 0. And then you can see welcome to the course, all of the weeks here, all the way to the final feedback piece. And each one expands, and you can see the content that's within each of them. So I'm going to walk you through. This is our welcome to our virtual training program. So it starts off with a welcome video. Welcome to the Trauma Therapy Program's Virtual Learning Center. This is Nancy and I, and we go on to welcome people, of course, to the training program and outline what they're going to be doing and how to work through the program. We then talk about our funding partners and some training program guidelines. We discuss the really important topic of vicarious trauma in healthcare providers, and I'm going to play just a tiny bit of that.
Hi, thanks for joining me. I'm Dr. Dana Ross. Today we are talking about vicarious trauma in healthcare professionals. Vicarious trauma can result from listening and being witness to people's experiences of trauma, but it is much more than burnout alone. It's about the care provider experiencing the profound grief and sorrow of trauma and essentially experiencing symptoms of trauma themselves. So as care providers, we can also find ourselves caught up in reenactments with clients that can bring up lots of difficult emotions and reactions. We're going to talk a lot more about reenactments throughout this course. We can experience symptoms such as anger, despair, fatigue, and all the other emotions and body sensations that come with listening to and witnessing people share their experiences of interpersonal trauma.
So you'll see that's a whiteboard animation and part of our multimedia approach. That goes on to talk about some of the symptoms, but also how do we counter vicarious trauma on an individual level, but also at an organizational level, a political level, a community level, etc. So then we move on to the few pre-questions, which Aysha was just sharing some of the data from. We have a facilitator guide. So I remember when I was first learning to co-facilitate R&R as a resident, it was very scary learning the content, but also trying to find language around, okay, I understand this concept intellectually, but how do I actually say this out loud in the group? The facilitator guide is something that can be downloaded. You can actually say you're learning the window of tolerance. You can actually just read the window of tolerance is X, Y, and Z, which is very helpful when you're starting. And then of course you find your own language and your own voice as you go forward. Then we have some bonus content throughout. So this is common group interventions. And this is Leslie Hughes, a therapist in our program. And she's talking about ways to intervene in the group to move it along, to help people with different kinds of regulation as well. And then we start into week 1. I'm going to walk you through this. All the weeks kind of are similar-ish in layout, different topics. So we start always with an introduction. We're going to talk this week about PTSD and complex PTSD. We had a biomedical illustrator really flesh out some of the concepts for us. So this one is people who've experienced interpersonal trauma often report struggling with isolation or having trouble connecting with others or feeling vulnerable with people in their life. And the sense of relational disconnection is captured in the illustration below. So it was hard to find like stock footage to capture that. So we were really happy to be able to have our bespoke illustrations. Then we have an outline. You can see we recommend how long to spend on each of these sections. And of course, as people go along in their community sites, they'll personalize this to their patient population. But again, when I was learning, I found it very helpful to have this kind of outline that I could follow. It helped with anxiety of co-facilitating for the first time. We also have sample guidelines if you're running a virtual or an in-person group. And of course, every site will have their own guidelines, but we wanted them to just be able to see what we're doing. Podcasts. So this is a podcast. Janet Lee Evoy and I are chatting about the 3 phases of trauma therapy. And it's 20 minutes in length. We had a few other podcasts that were 40 minutes in length. And one of the things I was really worried about was, will people be able to want to listen for that long? Will they have the time? Will they have the interest? And actually what we're finding in the feedback is the podcasts are one of the most popular pieces and people don't mind the length of the podcast and they appreciate the depth of the conversation that we go into. So that was just really kind of cool and interesting for us. This is another animated video. And then we go on to what is PTSD and complex PTSD. We've got Janet Lee Evoy and Abby Hirschler, and this is a live person
trauma therapist
video where they go on to talk about not just what is diagnostic criteria, but also some of the history of that as well. You'll notice all of our videos, all of our animations have closed captions, and they also have transcripts. This is hopes and fears about coming to this virtual group. I'm gonna play you this 2-minute video, and then afterwards I'm gonna frame it a little.
Hi again. We're going to talk about hopes and fears in coming to this group. It's not uncommon to have mixed feelings about, well, anything in life, but also most definitely about engaging in trauma therapy. It would make a lot of sense that you might feel nervous, scared, hopeful, excited, dread, hopeless, angry, or many other feelings. It can be helpful to unpack some of these mixed feelings. One way to unpack them is to think about your hopes and concerns or fears in coming to this group. Give yourself some time and space to reflect on what your hopes and aims are in coming to this group. What do you hope to gain? What are you hoping to learn? What made you take this brave step to register for this group? It's equally important to give time and space to reflect on your fears or concerns in coming to this group. What are you scared is going to happen? What are you scared you will learn or discover? Perhaps you were hesitant to join this group. Why? By spending time thinking about both your hopes and concerns, separately, but together, it may help you feel less mixed up about mixed feelings. It makes perfect sense that there'd be both hopes and fears. Take a moment and see if you can unpack some of those feelings yourself.
So that's an example of a video, and we took a very specific mindful choice. What we wanted to do was think about how can we help people find the language in delivering some of this content again. And so you'll notice this video is directed at patients, and this is what we would say in a group, as opposed to being directed at the healthcare providers who are taking the course. We wanted to provide that languaging from which people can sort of launch into their own style as they go along. We have how to use your 5 senses to resource yourself. Something on deep breathing here. Sushma runs us through a bunch of different deep breathing exercises. In R&R, we always have lots of different skills layered throughout all of the modules. And that is to help people experientially practice in the group, to ground, to feel a little bit more present, a little bit more centered. Every week has clinical pearls. So for example, do group participants ever get overwhelmed by reviewing the symptoms of trauma or the PTSD or complex PTSD handouts? And then we have, of course, an answer there, but we don't have time to review it today. We also end each unit with a test your learning. And so what are the 4 symptom clusters in PTSD according to the DSM-5? And you go in and there's a bit of a run through of what that is. And then you can go on to the next questions hidden there. Okay. According to Judith Herman's 3 stages of trauma approach, the work of mourning occurs mainly in which stage? And this is what Nancy was talking about earlier. And it takes us to an answer here. And then once we're finished with that, we are got 100%, good for us. And now we are into our next unit. So I'm going to stop sharing. And I'm going to bring up my slides and then I'll share here. Perfect. Okay. So that's a little bit of a taster of the very first iteration of this training program. And so we're going to be continuously evolving it, bringing in different consultants, education specialists, and continuously refining it, which is just a lot of fun. Right now, we're in phase 3, so we're in the process of implementing the resourced and resilient group at 6 of our community sites, followed by evaluation of the group by the client's healthcare providers. And we're going to be providing weekly virtual supervision to group facilitators, and that will be provided by TTP therapists. And the point of that is to offer support and supervision around group process, any comments around the group content and how to deliver that as well. Okay, and then we're going to be moving forward into phase 4 in about 2024 or so. We're going to increase access by collaborating with more community partners across the province, including rural, remote, underserviced communities. And we're really going to be looking at patient outcomes on a much larger scale here as well. So our vision for the future, complete phase 3-4, we have an Office of Scale and Spread at Women's College, which is fabulous. And they're going to help us really think right from the ground floor about how do we build this and how do we grow this. We have a couple of sister projects happening as well. So one is ER&R. It's a virtual treatment program for patients. So very similar kind of delivery to what we just watched. Patients asynchronously complete this and attend a 1-hour virtual group during the week where we discuss the content, answer any questions that come up. And then a third project is around needs assessment to develop a trauma-informed care course for multidisciplinary healthcare learners. And finally, this dream of dreams, which is TTP virtual, which is the idea of having Women's College Hospital be not only a center of expertise for clinical work, which it is, but also bringing in that center of expertise of research, of education. And part of that would be having this virtual platform, which is just packed full of resources of all different kinds for patients, for families, for community, for press. So that is sort of the dream where we're working towards. This is our wonderful team. This is us. This is my wonderful cat. Some references. And if you're interested in being a community partner, collaborating on bringing R&R to your community in 2024 and beyond, please email Annie, who's our research assistant. And if you're interested on more information just on the trauma therapy program at Women's College or how to make that referral, you can go to this link here or just Google Women's College Hospital Trauma Therapy Program. Will come right up. You'll find the referral form, etc. So that is the end, and I think we have time for Q&A.
Great. Thank you, Dana, Nancy, and Aysha. So there are questions already popping up in the Q&A, a lot really about accessing the training or different components of the training, the manual, the workbook, the online training, the podcasts, and people wondering if there's a way to access that now.
Yeah, well, it makes sense that people are interested in asking for sure. Right now, we're just testing this out from a research perspective, so we don't have it available yet. We want to really, put it through the paces and make sure we're getting the results we want before we're able to offer it on a larger scale. Nancy, anything you would add to that?
Yeah, I mean, I think this is always a dilemma with developing a new program, that it'd be so timely in this virtual world to be able to just send it out there. And at the same time, we really want to put some academic rigor to it as well before we just disperse it widely. I feel that's sort of our responsibility as a university hospital, to really make sure that what we're putting out there is a good evidence-based intervention, and that unfortunately tends to take far more time than we'd like it to. But our goal is to make it more widely available. But right now, we're not able to do that.
Also, a couple of questions in terms of what are the criteria to be considered to be a partner, and what would be involved in terms of the commitment of a partner, a community partner, in collaborating with TTP on this.
Wonderful. Well, we love partners, so please get in touch, and you can kind of answer any specific questions around that. But we really want to just be covering all kinds of different parts of the province, all kinds of different community populations and patient populations. So we don't have a strict criteria as of yet. We're thinking about putting together a committee to help us equitably decide who we're going to partner with and how many people we can partner with. But we're certainly at this point welcoming interest, and we'll be keeping a list and getting in touch with people around that.
One thing I would say about that is it's not a therapy training program. So it's a training program for therapists. So in our community partners, we're looking for people that already have psychotherapy within their scope of practice, and want to add this piece around trauma-focused care.
And Nancy, actually, your comment kind of leads us into someone else's question in terms of how you have seen this or envision this fitting in with other trauma training, other therapy modalities like CBT, for example, and whether partners are applying some of these things in individual therapy.
Yeah, so I'm not 100% sure about how the partners are, but certainly within our program, sometimes our therapists will offer this content in individual therapy when there are access issues around group. So, we may accommodate, although we're looking in the future to be able more and more to offer those kinds of accommodations in groups, say, for example, having translators, or having it available for people with hearing or visual impairment, because we really believe like the group component of it adds such richness and so many of those kind of universal elements of group therapy, as well as being improving access, but with efficiency, being able to serve more people. But people absolutely will do this individually, or, in individual therapy, pull out particular modules of it, not necessarily do the whole program, but teach a piece of it. Absolutely, yeah.
And there's a question about the age range of target clients. And I know we're an adult hospital, it's an adult program, but I'm wondering if there's been thought given, perhaps expanding on that question, to children and adolescents and kind of a broader scope of support for skills around trauma and understanding impacts of trauma.
Wonderful. So we're really excited about the idea of, as we expand this, go into phase 4, phase 5 eventually, are there like modules we can add on top for special populations, or can we collaborate with folks who work with adolescents and really shape an extra module or two, or reshape it entirely in some way? So we're kind of excited about all the possibilities and all the ways that this could go. Like it could be in a chronic pain clinic for people who also have trauma there. What would that look like? So really the sky's the limit in terms of those kind of options for collaboration. But again, it's the taking time of things and wanting to do them slowly, and then just getting excited in partnerships.
And there's another question sort of in that vein, but with a bit of a different spin in terms of other experiences of trauma beyond interpersonal trauma. So is there interest in applying this work to populations such as cancer survivors who experience their cancer illness and treatment is incredibly traumatic and can be experiencing post-traumatic stress symptoms related to medical experiences?
Absolutely, absolutely. There's a large percentage of folks who come to our program who have experienced medical trauma or trauma within the healthcare system. So we talk to people a lot about those experiences, but of course this isn't designed specifically for that. We would love to see that sort of evolution at some point, and again, be able to do those kind of partnerships.
And I am noting some really like practical questions about kind of referral process, other resources in the community, and some points of clarification. Like the website says only family physicians and psychiatrists can make referrals to TTP. Can psychologists refer directly? I know there's a lot of info that's actually on the Women's College TTP website, but I wonder if you folks want to take the opportunity just to clarify who can refer and how.
Yeah, so we do have a criteria that we do need a physician or nurse practitioner referral to the trauma therapy program. And there's some really practical reasons for this. And mainly around, as a hospital under the Public Hospitals Act, we need, the requirement is we need a doctor's order for treatment. And so not everyone that comes to our program is actually assessed by one of the psychiatrists when they come in. We have a multidisciplinary team who does the initial assessments. And so having a referral by a physician or a nurse practitioner sort of counts as our treatment order. So there's a really practical reason in terms of our volume. So, but many people are sort of recommended by, say, a community therapist or someone else in the person's circle of care, and then have them go to their family doctor to get their referral completed.
All right, and there's another question I'll sneak in there that kind of speaks to our eligibility for partners. And it sounds like just a query whether community partners are seen more as institutions or whether individuals can be community partners, individual therapists or folks who are training to be therapists and in supervised practice.
You'll let Dana speak to this about the range of kinds of partners we have right now.
Yeah, that's a great question. So right now, in terms of the type of partners we have two, one Tassin Hospital, a community hospital. We have a couple of community health centers, a couple of remote nurse practitioner-led clinics, a sexual assault clinic, Women's College Hospital family health team. So we have a real diversity of partners, but they're all definitely in organizations at this point. Would love to be able to offer at some point on that kind of individual scale, but we would really have to think about what that would look like and how we would be able to do that. So at this point, we're thinking more about community partnerships as well. We're also thinking about one of the reasons for that is we've partnered with places before this project existed and offered R&R, but we've partnered with and trained, say, one person at a community partnership, and then that person moves on and it kind of dissolves, right? And so we want to be with organizations where we can train multiple people, so it becomes sort of embedded in the program and really adopted by the system and then personalized by them as well.
Thank you. And I mean, it sounds like there is a lot of interest in knowing where outside of TTP folks can kind of refer clients or patients. So I wonder if it's something that you can name, some perhaps community partners or like strong community resources that are offering trauma therapy now too.
Nancy, on the website, do we have a list of resources?
I think there is a list of community resources on the website. along with the referral of, various things in Toronto, things like Family Services of Toronto and Barbara Schleifer Center. So there is a list there of, great places for people to look for care. But I mean, this is the same dilemma that we have, which is part of the reason that we developed this group, right? Like it felt like it wasn't really fair to say, well, go out in the community and do your stage 1 work and then come here to us, when people couldn't find that or had long wait lists there too. And so it's part of the reason that we've developed these kinds of programs.
Yeah, thank you. So hopefully for the person with that question, we can direct you to the website for a bit more kind of a concrete list. There's a question about how one deals with suicidality in the program as a therapist, and I guess how that's addressed in the training modules too.
Yeah, I mean, I would say that we deal with it, I guess, the same way that one would with any suicidal patient. We have lots and lots of patients that have chronic suicidal ideation, and so we assess what we think the acute risk is. Many people will continue to be chronically suicidal in our program, and we don't intervene further. We talk about it, and how that can be another one of those kind of like thinking about suicide can actually be a coping strategy. But when we assess that there's an acute risk, we, the therapists will have one of the psychiatrists who's on call come and assess, and we'll send people to emerge if we need to, if we have that acute a risk. But I think we have, with our population, we tend to have a pretty wide window of tolerance for suicidal ideation, which might not be appropriate in a different population.
Great. Thank you, Nancy. And, folks reaching out to inquire again about the referral process and about being community partners, I'll just maybe redirect people to emailing Annie at the email address that Dana, Nancy, and Aysha provided on the slide, and to the Women's College website for those kind of practical questions. The other ask is if the reference list for your presentation can be shared with folks as a resource to carry forward.
Yes, we don't know how technically to do that, and we maybe can give it to the organizers, or I can go back, let's see, or not, and people could take like a screenshot if they want to this page, and then there's one other page.
Perfect. Thank you, Dana. And I'll also name for folks, we are kind of recording, and the citywide grand rounds continue to be available to access and kind of rewatch and hold on the reference slides, but we'll double check, and maybe Raj, you can answer if there's a way to kind of physically share the references with attendees.
Yeah, thank you, Dana, Nancy, and Aysha, and Joey for your moderation. It's a wonderful talk and very engaging. I really appreciate all the time you put into it. I'm intrigued by the platform and all the interactivity components. It really looks very nice. And Simone as well for coordinating the overall as of PIC. So really appreciate it. Thank you for that. As far as the question about the references, you can send it to Paula, and Paula and I will figure out a way that we can maybe send it to the attendees so they can have the references, and that'll be helpful. If there's anything else that you wanted to attach, like resources or something that you feel like would be helpful, we can send it out in that attachment as well. And so once again, thank you, everyone. I would just put one thing, if it's possible, if I can share the slide here. Let's see. Hopefully you can see my slide here. The only thing I would like to add is, again, thank you for joining us today in our citywide grand rounds. It's really appreciated. took the time to do this. I just wanted to add that our next citywide grand rounds is in February 25th, and hopefully you'll be able to join us. We have a very interesting talk on how antidepressants work and how it can be used to improve treatment in the future. It's a collaboration with our Oxford partners. Dr. Catherine Hammer is going to be presenting, so hopefully you'll be able to join us. So thank you again for everyone for joining us today. Take care, and we'll see you hopefully next month. Bye.
Thank you.